Hey, good morning, everyone. Thank you so much for having me here and for this nice introduction. Today, I'm going to be talking about the different modalities of diagnosing and treatment of TMJ. And as you can see, TMJ is mainly one of the most important joints in the body and stress. So I'm just going to start with the normal anatomy of the temporomandibular joint. It is one of the most complex and used joints in the body. It is subject to complex vector forces due to masticatory muscular parafunctional habits. For the anatomy, I'm not going to go into details of the anatomy. I'm sure most of us, if not all, know exactly what is the anatomy of the TMJ and what are the different ligaments and muscles that surround the TMJ. But I'm going to go ahead and discuss the temporomandibular disorders, which is why exactly I'm here today. So what are the cardinal TMD signs and symptoms? The most important signs and symptoms for TMD are the masseter muscle pain, the TMJ pain, the temporalis muscle pain, mouth opening limitations, and the TMJ sounds. Now, pain by far is the most common reason that patients seek treatment. TMD is extremely common. I can tell you it's definitely much more common also in ladies in the ages between 20 to 40. 33% of the population has at least one TMD symptom in their lifetime. So if I take any three of you now, at least one of every three will have some TMD symptoms sometimes in their life. About 3.5 to 7% of the population has TMD with sufficient severity to seek treatment. Now, the symptoms can be really very confusing. It can fluctuate over time. It can be definitely correlated with parafunctional habits. And if we're talking about the parafunctional habits, definitely we can see increasing number of patients that are coming in with lots of parafunctional habits that they are not aware of. Now, the psychosocial factors, which is one of the most important things that we are seeing on the rise in the last few years. Now, this might be misinterpreted as what are the different factors that are causing the huge increase in stress worldwide. And I would like to actually use this opportunity to mention this, that the amount of stress around the world has been on the rise since the COVID hit in 2020, and then the Russian-Ukrainian war in 2022, and then finally the genocide that's happening in Gaza that started in 2023 and still ongoing. I am in network with so many people around the world, and I've just actually received a call from one of my best friends that all of his 57 family members have been killed in the genocide that's happening in Gaza. Yes, this is actually ongoing right now. More than 100,000 people have been either killed, injured, or buried under the rubble in the last 6 months. So I think it's time for all the 8 billion people watching this happening around the world to call for an immediate ceasefire and to hold everyone responsible before this starts affecting the whole world. Now, yes, this is causing severe frustration, severe depression, severe irritation, and of course, causing lots of more patients to come and seek TMD treatment. TMD can also cause dizziness, tinnitus, neck pain, toothache. Now, the problem is with these ones that I just mentioned, now the dizziness, the tinnitus, the neck pain, the toothache, that confuses lots of general dentists. Every single day, I get patients that come in and tell me, we've been seeing from 4 to 7 different providers, whether medical or dental, whether it's an ENT specialist or an oral surgeon or a prosthodontist or a general dentist. And at the end of the day, they end up spending between $3,000 to $5,000 US without reaching the final diagnosis. And that's simply because every single practitioner has been just trying to focus on their comfort zone and seeing the second, third, or fourth complaint and not focusing on the chief complaint. So I think this is time for every single medical and dental practitioner to start focusing on the primary chief complaint before going ahead with their comfort zone treatment plan. Let's put it this way. TMD is definitely a greater problem for females. As I mentioned, we are seeing a ratio up to 9-to-1 females to males. I can tell you 95% of my patients are females. And this is because there's a huge effect of hormones on the TMJ joint specifically. Now, the exact underlying reason is not understandable, but we are 100% sure that hormones play a huge, significant effect on the TMJ. TMD is a multifactorial disorder, and that's why it's not only enough for one practitioner to treat the TMD. We have physicians, physical therapists, chiropractors, massage therapists, psychologists, psychiatrists, orthodontists, prosthodontists, and general dentists, all trying to come and treat this TMD. Now, I know everyone is going to say, wow, we need like 5 to 10 different specialties just to treat some clicking. Can't he just go and get some night guard and be quiet? So I get this comment from sometimes different providers and different patients, like, why are you making a big deal about it? It's just some clicking. It's just some TMJ pain due to stress and it's going to go away. Well, unfortunately, this is not the reality. The American Academy of Orofacial Pain has been struggling for 55 years to get this specialty accredited. And due to political reasons, this was not accredited until the COVID hit in March 2020. That was the date when the American Dental Association decided to accredit the oral medicine and orofacial pain as accredited specialties. And that's because they realized that it needs to be an accredited specialty, because there has been so much misreferrals from medical and dental specialists that were not able to treat these cases and were either sending it to the ENT specialists and thinking that it's an ear infection, or sending it to an oral surgeon to just go ahead and extract all the 4 wisdom teeth, thinking that it's just some pain from the wisdom teeth, or even worse, sending it to an endodontist and thinking that just 1 or 2 teeth need some root canal treatment and everything is going to be fine after that. Now, I'm sorry to say that all these things sometimes might not have even needed at all. And sometimes they're needed, but there were second or third or fourth complaints, not the chief complaint. The result is, again, patients coming to me in the clinic every single week in Marquette University. And I'm saying again, every single week, saying we have been to about different providers and they give us antibiotics. They give us sometimes some muscle relaxers. They extracted my wisdom teeth. They did 5 to 7 fillings. They did 2 root canal treatments. And imagine what? The pain is getting worse because every time you're operating on a TMD problem without solving it, you're actually making it worse. So I think it's time for all the medical and dental specialists around the world to approve and know that there is a big problem called TMJ that is not going to be resolved by just doing other dental treatments. So when should we recommend TMD therapy? If the patient has significant temporal headaches, preauricular pain, jaw pain, TMJ locking or catching, loud TMJ noises, restricted opening, difficulty eating, or any other non-pathological otalgia due to TMD. Now, again, this is the most important slide I was just mentioning now. primary, secondary, tertiary diagnosis, contributing factors, and symptom patterns. It is very important for every one of us to take a moment before you decide on your treatment plan to check what is the primary diagnosis of this patient. If we are all going to focus on just making more money or just trying to go into your comfort zone and give the treatment that you think is the right treatment for the patient without doing your due diligence to make sure that you're not ignoring the chief complaint, then I'm sorry to say you're going to be in a vicious cycle. Because I keep seeing these patients every single day coming, crying in tears, saying that why didn't our previous dentists or physicians let us know to start treating this TMD at the first point and not at the last point. So yes, the primary diagnosis is the most important thing. It can be of TMD origin. It can be of non-TMD origin, like pulpal pathosis, like sinusitis, like cervicogenic headaches. And then after you're done with treating the primary diagnosis, then you can start treating your secondary or tertiary or any other diagnosis. Now, contributing factors, of course, are a lot, and we see them also on the rise. Nighttime power functional habits, gum chewing, daytime clenching, stresses, neck pain. It's important to know how these symptom patterns happen. It's important to ask the patient, what time of the day you get more pain? Does the pain get worse in the morning or in the evening? And also the location. Where does it start? So yes, patient interview is very, very important. I spend about 1 hour with every new patient just to be able to know exactly what is going on, what started this TMJ problem, and if it is even a TMJ problem or something else. So yes, please take the time, build the rapport with your patient. It is very important, especially nowadays, that unfortunately we go to different practitioners around the world, and we see them literally finishing or ending the consultation in 3 to 4 minutes just because they're busy. They want to make more money by seeing other people. Now, let me remind you that you are treating human beings. You're not treating robots over here. I remember the last time I went to a dermatologist, like a few years ago, and he literally spent 3.5 minutes with me. 3.5 minutes. Of course, I didn't tell him that I'm a provider. I wanted to see how he treats different people. And it was 3.5 minutes. He charged me $450. And then he told me, if you need anything, just ask the nurse. What kind of world are we living in? Is this how you would be able to treat your spouse, your dad or mom, your sister, your girlfriend? I don't think so. So I think it's time for all of us to start thinking that if you don't use your consciousness and really treat the patients as human beings, then we are going in the wrong direction. Pain quality is another question that we also have to ask, whether it's just dull ache pain or is it a throbbing pain? The throbbing pain might mean that there is some migraine headaches. There might be also some referred pain from other issues like tooth or other muscles, or sometimes it can even be a referred pain from other tumors. Sometimes it's burning pain, and the burning pain can also be either just minimal or it can be a major neuropathic pain. So yes, if the patient, for example, comes and tells you, I have sharp shooting pain that comes for a few seconds or a few minutes, and sometimes it's triggered by certain factors, for example, for men while shaving or just touching your face, for ladies while putting their makeup, or even while driving in a cold country and having your windows open and having all this cold air coming onto your left side or right side of your face, depending on which side you're driving. We see a lot of cases, especially with the change of seasons, We saw so many cases during the COVID because of the huge amount of stress that happened, the huge amount of domestic violence that increased a lot inside the world and specifically in the United States. I can tell you because I'm the only specialist in Marquette University that sees these types of patients, that we have seen about a 25-fold increase of these types of patients in the last 4 to 5 years. Pain parameters, yes, you need to ask, what's the pain intensity? Is it 1, 2, is it 10? The frequency, is it daily, weekly, monthly? What is the duration? We have cervical pain also. We have post-traumatic stress disorders. Again, PTSD is also on the rise. We have fibromyalgia. I think about 25% of my patients now are diagnosed with fibromyalgia, which means about 1 out of every 4 patients have fibromyalgia. And again, we are not sure why there is a huge increase in the cases of fibromyalgia. After we're done with the history taking, or what we call the interviewing of the patient, then we do the clinical examination or the range of motion. We have to check what is the maximum opening, what is the lateral opening, and what is the protrusive opening. We have average numbers of 40 millimeters, of course, plus minus 5, 7 plus minus 2 for the lateral, and 6 plus minus 2 for the protrusive. And you can easily just use a simple ruler to check that. TMJ noises is one of the important slides that I have for you today also. There's only 2 types of TMJ noises, either clicking or crepitus. We usually see the clicking sounds in younger population, and that is due to disc displacement. Again, also most commonly in females. But we also have another type of sound that is called crepitus, or what we call crackling or grating, or maybe an easier way to say it is eggshell cracking. When you apply your thumb on the TMJ on both sides and you ask the patient to open their mouths, you can literally feel as if you're feeling an eggshell cracking under your finger. You hear it and you feel it. Crepitus would most probably, if not completely, be responsible or denoting that there is arthritis. So if you feel that there is crepitus, this means the patient has arthritis. But if you only feel the clicking, then the patient is just having a disc displacement. So yes, we have to apply palpations. You have to palpate the TMJ, and then we palpate the masseter muscle, frontal, temporal, occipital, SCM, and trapezius. All these muscles can be part of the TMD, and you would need to know if there is any tightness in these muscles or not. Now, very important to know that you have to apply firm, sustained pressure on these spots. I usually see my students when I'm teaching them, they all come back to me and say, well, we applied the pressure, we didn't find anything. The patient is in perfect condition. I go there and I start applying my sustained pressure and the patient screams and jumps to the ceiling. Why is this? We need to know that if you are just going to touch the patient's skin, you're not doing anything. You're just deceiving yourself. There has to be a sustained, firm pressure, and then you have to see how the patient reacts. It's either a 0, 1, 2, or 3. 0, no reaction at all. 1, patient has mild reaction on their face. 2, patients will literally try to take away their face or shoulders from under your hands. 3, which is severe, patients will jump into the ceiling. So yes, you cannot ask the patient how much is it from 0 to 10, because different patients have different tolerance. If I take the 3 ladies at the end of here and do the same exam, I'm sure one of you will tell me 3, other one will tell me 5, and the other one will tell me 7. Because everyone has a different tolerance to pain. But depending on the reaction that I see on your face while I'm doing the sustained firm pressure, I will be able to decide if it's a 1, 2, or 3. This is one of the most common mistakes that I see with my students. After you're done with the extraoral examination, then you will do the intraoral examination. You would need to, of course, do your questionnaire, check if there is any swelling, check if there is any abnormal restorations, and check if there is any hyper responsiveness to any of these tubes. Now, imaging, which is also another conflict, or let me put it this way, some orofacial pain centers, whether in the States or other parts around the world, are misusing or abusing the imaging technology for the TMD. How is that? There's different types, of course, different types of imaging that we can use to diagnose TMJ. There's the plain radiographs, the panoramics, CTs, the cone beam CTs. We can definitely see sometimes different types of osseous demineralizations. There's the MRI if you want to find out if there's any problem with the soft tissue or the disc. But here's the question. TMJ is different than general dentistry. Do we actually need to ask every single patient coming to us to do a panoramic X-ray and a CBCT and an MRI by default, just to let the patient look at their joints and make them pay up to $5,000? That's the equivalent of these X-rays in the States if you don't have insurance? Of course not. And this is a problem that I see in many, many centers. Well, we need to know that the imaging would be about 6 months lagging after what is actually clinically happening in those patients. So if you're going to be depending on X-rays to diagnose a problem, you're 6 months behind the actual diagnosis. So again, 95% of the treatment for the TMJ does not need you to do a CBCT and an MRI, because basically it's not going to change your diagnosis or treatment plan. The only two conditions that you need to do a CBCT and MRI, if two things only. If the patient just had an accident and you're suspicious of a fracture, or if you're suspicious of a lesion or a tumor. And these are the two conditions that you need before touching the patient to get the CBCT and the MRI. Other than that, it will be a waste of time, energy, and money and radiation exposure if you decide to do that for every single patient. TMD diagnostic categories. We have lots of TMD patients that have, as we mentioned, muscle pain or TMJ noise. What are the TMJ articular disorders? Remember, TMJ or TMD can be either articular, which means a joint problem, or muscular, which means a muscular problem, or both articular and muscular problems. So again, any patient complaining of TMJ problems is one of three, either purely articular or purely muscular, or both articular and muscular. Diagnosis of the articular disorders are as follows, from the most common to the least common, starting with the disc displacement with reduction, then without acute disc displacement without reduction, chronic displacement without reduction, and then going down through the list: dislocation, inflammatory disorders, arthritis, ankylosing, fracture, and finally some congenital or developmental disorders. Now, it's worth mentioning that sometimes we see some swellings on the TMJ area. Is it common to find a tumor in the TMJ? I haven't seen any except maybe 2 or 3 cases in the last 15 years. It's very rare to find a tumor inside the TMJ itself. But when we most commonly see a swelling around the TMJ area, it's most probably one of 2 things. Anyone here? I want to be interactive here. Okay. So the first one would be parotid gland swelling. We see that a lot. If the patient has a parotid gland inflammation or swelling, it might represent the swelling around the TMJ. It might confuse you and you might think that it is a TMJ problem. And the second thing is a hypertrophy in the masseter muscle extending literally throughout the whole right or left side of the face, to the extent that you might think that there's a swelling in the TMJ itself. So these are the 2 most common types of swellings that we see around the TMJ, either a hypertrophy of the masseter muscle or a parotid gland swelling or inflammation. The masticatory muscle disorders are myofascial pain, myositis, myospasm, myofibrotic contracture, local myalgia, neoplasia. The most important thing that I want you to know here is the difference between the myositis and the myospasm. because of course myositis means itis means infection. So you need to prescribe an antibiotic. But if it's a myspasm, then you need to prescribe a muscle relaxer. So you need to identify whether it's an infection or muscle tightness. The contributing factors are biological, behavioral, emotional, cognitive, social, environmental. Most of them are biological. I would say very important advice for us here before we advise or talk with our patients. We need to talk with ourselves. The number one, most people on earth that have neck posture problems, back posture problems are dentists. Yes. Unfortunately, ask any dentist who has been practicing for 15 or more years, they will tell you, oh yes, my back is not the same anymore. My neck is not the same anymore. And new surgeons, just like my brother. So yes, surgeons and dentists are the most affected populations by their job affecting their neck and back posture. A survey was done in one of the dental schools in the United States of America during taking the dental exam, and they found that 78% of the dental students had a bad posture while treating their patients. That was done during taking the exam. So yes, we need to make sure that we have the good and the right posture while treating our patients, because you know what? If you start developing a bad habit while you're a dental student, you will continue using that bad habit and bad posture for the rest of your life. And I can assure you that by age 45 to 50, you will start having a neck or back pain. So you need to start with ourselves even before talking to our patients about this point. Behavioral, and I think we spoke about that, but I'll just focus on a little bit of more important points, which is the clenching, the fingernail biting, the stomach sleeping, the telephone cradling. And unfortunately, until now, while I'm giving my lectures, I see some of my students doing this fingernail biting while I'm doing the lecture, talking about the behavioral factors. So it's time for all of us, I think, as dentists also to start realizing that we ourselves are having some of these bad habits that can cause TMJ problems. Telephone cradling, and I really am not sure why until now, even in the United States, while I'm driving every day in the morning to my work, I find people that are still holding their phones with their hands. Although we have all this Bluetooth technology, people are still holding phones while driving. And of course, I'm not talking about TMJ problems here. I'm talking about much more serious problems. Most of the fatalities on the roads around the world are because of talking on the phone while driving. I hope no one here is doing that until now. Please use your Bluetooth. That's the reason for that. Or don't even use it at all. You should focus on the driving. Anyways. Emotional. Yes, depression, worriness, anxiety, anger, all this have huge contributing factors on TMJ. Cognitive, of course, also. You need to think positive. You need to avoid negative self-statements because this will definitely on the long term affect your TMJ. Social, and we can see the rise in the amount of bullying around the co-workers and around the students in the whole world now, which is affecting a huge amount of people. We need to be aware of that. We need to not allow, there should be zero tolerance for any type of bullying anywhere in the world. Environmental, which is not that much common. Treatment. Okay, I know most of you are here for this part. How can we treat TMJ? Okay, patient comes in, they have some TMJ problems. There are 6 different steps that we can go through to treat a TMJ. Starting with self-management therapy. And I know most of you would say, okay, who cares about self-management? Who cares about self-management? Let's just move to the next point. I'm going to tell you, number 1 is the most important one. Taking the time to give the handouts to the patients and to discuss the details with the patient is the number 1 contributing factor to the success of your treatment. And that's why I spend that 1 hour with my patients. Because unfortunately, what I see in many, many clinics around the world, and by the way, I have visited about 22 countries and lived and worked in about 6 countries. And I've intentionally visited different providers to see how they treat patients. And unfortunately, I can see that, again, spending between 3 to 7 minutes, 10 minutes, and then just throwing some handouts in the patients' faces and just telling them, good luck, read it. If you have any questions, let me know. Well, let me tell you something. Most of the patients, and this has been a survey done, that see this type of treatment for their doctors, number one, they're going to throw the handouts in the first garbage bin after they come out of the clinic. Number two, they're most probably not understanding anything of what you said. Number three, even if they understood, they're not going to trust you anymore because they feel that you don't even treat them as human beings. So please wake up. Wake up and know that you're treating human beings. You're not treating robots. Now, what is meant by consented handouts or self-consent? You need to discuss with the patient every single detail. And then the only way that you're sure that the patient's got this information is to ask them to reiterate this information back to you. That's what I do. So after discussing every single step, you ask them, okay, what did I do? What did I just say? Say it back. And most of the times you'll find that they're not able to say it back because, again, you need to know that you have to discuss these in details with them and follow up with them. You should have a follow-up system through your nurse in the clinic or even by yourself every couple of weeks, every couple of months to make sure that the patient is actually following up on the instructions. Now, yes, home physiotherapeutics, good daytime posture, training from opening widely, avoiding chewing gums, even avoiding caffeine, limiting caffeine. I know this might be a new information for some of you, but yes, caffeine has been shown to affect negatively your TMJ. And especially in the United States of America, where you have providers coming in the morning with these huge mugs, I don't know how they drink them throughout the whole day, with about 5 liters of coffee. And they finish them and they refill them 3 times a day. And I'm like, how can you even survive like this? I still remember, and I'm not going to mention names here, but my program director in one of the 3 programs that I did around the world used to drink from 7 to 10 glasses or cups of coffee a day. And he was the program director of the orofacial pain. While treating his patients, his hands used to shake because of the huge amount of caffeine, to the extent that one of the patients told him, "Are you okay?" And he told him, "Yeah, I just drank 7 cups of coffee today. I'm fine." And literally 2 minutes later, he was advising the patient not to drink caffeine. What type of role model do you think we are playing in this world? If you want to be a role model for your kids, you have to be a good dad. And if you want to be a role model for your patients, be a good person before being a good doctor. Okay. Avoid touching teeth. Avoid other oral habits. Practice draining tension from your jaw and neck. Keep masticatory muscles relaxed. Use over-the-counter medications as needed. And avoid stomach sleeping. This is especially addressed to the ladies here. 90% of my patients that are ladies, they say they sleep on their stomach. And this is one of the worst habits that you can do. Please stop sleeping on your stomach and start sleeping on either your back or side. Physical medicine. Yes. Massage therapy, yogas. And to be honest with you, I personally, although I thankfully do not have a TMJ problem until now, but I do yoga, I do massage therapy at least every month. Physical therapy, chiropractic, all these things will help a lot. One of the most important things that I do in Marquette University is the trigger point compressions or the trigger point injections, where we literally find the knots that are affected mainly in the masseter, the SCM, and the trapezius, and the frontal and the temporal, and we inject local anesthetics inside them, whether they're carbocaine, lidocaine. This helps a lot to cure and to reduce the amount of tightness in these muscles for at least 3 to 4 weeks. Cognitive behavioral intervention, and this can be done through psychologists that are specialized in TMD. Pharmacological management. Lots of patients, lots of dentists think that by just prescribing some Advil or muscle relaxers, they will solve their patient's problems. And I'm here to tell you, this is not true. Yes, they will help maybe 10, 20, 30%, but you would have to actually go and see what are the contributing factors. What are the systemic factors? What is causing the TMJ? Not all TMJ cases can be treated by just prescribing a muscle relaxer and an Advil. Now, maybe the most important thing that I want to just talk about for the pharmacological management, we mentioned TMD can be either articular, muscular, or both. If it's an articular, you're going to prescribe an anti-inflammation medication, so most probably like non-steroidals. So maybe meloxicam, maybe naproxen, ibuprofen. If it's a muscular problem, then you're going to prescribe a muscle relaxer like the baclofen or cyclobenzaprine. Prosthodontic therapy, and we have occlusal equilibration, or different types of night guards, and I'm not gonna go into the details of this. There's also intra-articular injections, which really helps a lot. We can inject tinoxicam or hyaluronic acid or other bioactive compounds that can be also very important for the treatment of TMD. The intramuscular injections, which I just mentioned, we can inject local anesthetics, or we can also inject collagen into the muscles, which has been also showing to be of huge significance effect. Now, this is the most recent types of treatment for TMD, and this is maybe if you want to take a copy of that. And I'm going to make sure that you all have access to all the slides so we can get it. But this is the most important slide that shows all the different types of treatment for TMJ, whether it's preclinical studies or phase 1 or phase 2, or actually going into the phase 3 and the phase 4. Since there's not enough time during this lecture to discuss the details of all this, again, I will be also available after the session to discuss any details for anyone as needed. Finally, the TMJ surgery, and this is very important. We do not refer our patients for surgery unless conservative treatment fails. So yes, I'm going to say this again. We always, and we in most of the cases, are able to succeed in helping 95% of the patients by conservative treatment. Patients who do not respond to conservative treatment, or of course, if they have congenital problems or fracture, then these are the conditions that will be needing treatment by surgery. And the simplest surgery procedures are the arthrocentesis, the arthroscopy, and then the most complicated ones would be the orthognathic surgeries, open joint surgery, modified condylotomy, or joint replacement. Thank you so much. I have it in different languages for everyone. Thank you.